welcome you all back to this series of lectures on cardiology. Today we will be talking about aortic regurgitation. Okay, so let us move on to see what is this aortic regurgitation. As we all know, and if you had seen this lecture on aortic stenosis, the aortic valve is basically present between the aorta and the left ventricle. So whenever there is regurgitation or backward flow of the blood during the pumping of the heart, this is what we call as aortic regurgitation. So let us look at some of the most important etiological factors which are associated with AR. So AR can be because of valve lesion, it can be because of a valvular lesion, or it can be because of aortic root diseases. So when we come to the etiologies, we have the bicuspid aortic valve. You would have all seen, or you would have all known that bicuspid aortic valve is most commonly associated with AS, but bicuspid aortic valve can be associated with AR as well. Then infective endocarditis, rheumatic fever. Remember that in rheumatic fever, aortic valve diseases does not happen independently. Aortic valve diseases does not happen independently. Rather, it happens in the presence of MS or MR. Okay, it happens in the presence of MS or MR. Then there can be myxomatous degeneration of the valve. Apart from that, radiation and trauma and syphilis can also cause aortic regurgitation. Aortic regurgitation is also associated with some connective tissue disorders like Takayasu arteritis, and it can also be seen with ankylosing spondylosis. Right? So it can also be seen with ankylosing spondylosis. Right? Then aortic root diseases. Aortic root diseases can be seen with aortic dissection. It can be seen with medial degeneration, Marfan syndrome. It can be seen with aortitis and hypertension. So all the disorders which can cause root dilatation, including syphilis. Syphilis can cause root dilatation as well. It causes syphilitic aortic regurgitation. Aortic dissection, medial degeneration, Marfan syndrome, aortitis, all of these are associated with aortic regurgitation. And don't forget the connective tissue disorders which are associated with AR. Okay, so that is about aortic regurgitation etiologies. Now, let us move on to the hemodynamics of aortic regurgitation. So, in acute AR, when do you get an acute AR? When do you get an acute AR? So, acute AR can happen secondary to infective endocarditis. It can happen secondary to trauma. So, what happens when there is an acute AR? The blood that flows here flows back into a non-compliant ventricle. It flows into a non-compliant ventricle. Correct? Because the ventricle is not expecting the aortic regurgitation to happen. It has not dilated. There is no compensation. So, there is some amount of non-compliance here. Now, but what happens is that the heart is hypercontractile. The heart becomes hypercontractile. Why? Because it gets a huge volume of blood. Whatever blood goes forward, there is regurgitation of blood to the LV. So, whatever blood goes forward, there is a backward flow or a regurgitation back to the LV. So, what happens is that the volume increases, and as a result of the Frank-Starling law, the contraction also increases. So, the heart becomes hypercontractile, right? So, in the initial time, what happens is that the heart becomes hypercontractile, and what happens to the blood pressure as a result? The blood pressure, especially the systolic blood pressure, increases. The systolic blood pressure increases. But what happens to the diastolic blood pressure? The diastolic blood pressure falls. Okay, so the systolic blood pressure increases and the diastolic blood pressure falls. In the initial stages of acute aortic regurgitation, what happens to the ejection fraction? The ejection fraction is furiously increased. The ejection fraction is furiously increased. So, the initial stages of aortic regurgitation, the ejection fraction is furiously increased because of the hypercontractile heart. So, that is about the hemodynamics of acute AR. Now let us look at so what happens in chronic compensated AR. So over the course of time, what happens is that there is a lot of regurgitation. So it goes into a state of chronic volume overload. It goes into a state of chronic volume overload. Correct? It goes into a state of chronic volume overload. So what happens as a result of this? The ventricle begins to compensate by what? By compensates by dilatation of the ventricle. So there is dilatation of the LV over the course of time. Okay. Then this can happen to a certain extent, right? The LV can stretch to a certain extent, but beyond the point of which the hypercontractility also will start coming down. So the blood pressure will start coming down as the LV begins to fade. LV begins to fade, and the LV will not be able to compensate for the extra volume of blood, and the end diastolic volume begins to increase. So the blood pressure begins to fall and the end diastolic volume begins to increase. Okay. Now, once there is a decompensation, you notice that the LV and the LA become completely dilated. Right? So the LV and the LA become dilated to a huge extent, and the end diastolic volume, that means that there is large amount of pooling of the blood in the LV. So the end diastolic volume increases, and over the course of time what happens is that the end diastolic volume increases, the LA pressure also increases. That means that the pulmonary capillary wedge pressure can increase, and there can be development of pulmonary edema with LV failure. With LV failure, there can be development of pulmonary edema and dyspnea. Fine. So this is about the hemodynamics of AR. Now let us look at the symptoms. Right. So why is there palpitations? This chronic volume overload state. Whenever there is a chronic volume overload state, what does the heart try to do? There is a hypercontractile heart. So what happens to the heart rate? The heart rate increases. So because of tachycardia and chronic volume overload states, this is felt as palpitations. So any chronic volume overload state like mitral regurgitation and aortic regurgitation is associated with palpitations. There can be nocturnal angina. So a very characteristic feature which is seen in aortic regurgitation is the presence of this nocturnal angina. So what happens is that when you sleep, what happens to the heart rate? The heart rate reduces. There is bradycardia. Now, when there is bradycardia, what happens to the duration of diastole? The duration of diastole increases. So, during sleep, there is bradycardia, the duration of diastole increases and the regurgitation increases. So, if the regurgitation increases, the flow to the coronaries is reduced. So, whenever there is more duration of diastole, more regurgitation, the flow to the coronaries is reduced, and that is why you get your nocturnal angina in aortic regurgitation. There can be dyspnea. Yes, because of the volume overload and the pulmonary congestion, there can be dyspnea. What happens during exercise? Exercise usually is tolerated. Right? Because during exercise, the regurgitation comes down slightly and the exercise is usually tolerated in aortic regurgitation. Fine. Now the signs, the very interesting signs which are seen are the peripheral signs of aortic regurgitation. As I had mentioned in the initial stages of AR, what happens? The systolic blood pressure increases and the diastolic blood pressure falls. It's nothing but what we call as the pulse pressure. So what is the pulse pressure? It is the systolic blood pressure minus the diastolic blood pressure. So the systolic blood pressure increases and the diastolic blood pressure falls, and this is what we call as the pulse pressure. So there is a wide pulse pressure, and as a result of which it results in a multitude of peripheral signs that we call as the peripheral signs of AR. So let us look at the peripheral signs of AR one by one. The first sign is your Corrigan's sign. So there is prominent carotid and supraclavicular pulsations. Once you see a patient of AR, you will never forget the peripheral signs of AR. Okay. So Corrigan sign basically refers to the prominent carotid pulsations. What is the Demosid sign? The head bobbing which occurs with every heartbeat like this. This is what is called as the Demosid sign. What is the Landolphin sign? There is a change in the pupil size. So there can be alternate contraction and dilatation of the pupil with every heartbeat, and this is what we call as the Landolphin sign. Then we come to the Muller sign. Pulsation in the uvula is called as the Muller sign. What is the Becker sign? There can be retinal artery pulsations, right? The retinal column also goes up and down, and this is what we call as the Becker sign. Then we have the Rosenbach and Gerhardt sign. On per abdomen examination, you can find liver and spleen pulsations. This is what we call as the Rosenbach and Gerhardt sign. Then what is the Quincke sign? There can be digital capillary pulsations. If you see the capillary pulsations over the nail bed, if you just press it and leave it, you can see that there can be alternate pulsations which are seen, which is known as the Quincke sign. Then what is this lighthouse sign? There can be blanching and flushing of the forehead. The alternate blanching and flushing of the forehead. Then the Traub's sign. What is the Traub's sign? A pistol shot femoral sound. So if you place your stethoscope over the femoral artery, you can find a pistol shot booming type of sound which is heard, which is known as the Traub's sign. Okay. Then what is the Burozzi sign? What is the Burozzi sign? There can be intermittent to and fro systolic diastolic murmurs which are heard over the femoral artery. Because of the wide pulse pressure, you can hear a murmur over the femoral artery which is called as the Burozzi sign. The most important that you have to remember here is the Hill's sign. So Hill's sign basically means that the lower limb BP is more than the upper limb BP by more than 20 millimeters of mercury. So the presence of Hill's sign is used for grading of the clinical severity of aortic stenosis. If the Hill's sign is more than 30, 40, then it means that this is a severe aortic regurgitation. Right? So the Hill's sign is basically used to grade the severity of aortic regurgitation. What is the water hammer pulse? If you have gone through the lecture on pulse, you will understand what the water hammer pulse is. This is also called as the collapsing pulse, where there is a rapid upstroke and a rapid downstroke because of the wide pulse pressure and the peripheral runoff. So this is what we call as the water hammer pulse. Then you also have the Lincoln sign, which is nothing but the pulsatile popliteal arteries. So pulsations literally everywhere, and each of the pulsations in each of the areas are given different signs and names. Okay. So this is about the peripheral signs of aortic regurgitation. Fine. Now let us move ahead and understand what are the other signs that you can find. So what happens to the pulse? The pulse that you see in aortic regurgitation is your collapsing pulse. Fine. What happens to the BP? The systolic blood pressure is high and the diastolic blood pressure is low. You find diastolic blood pressure of 30, 20. That means that the Korsakoff sounds are heard. Despite you reducing the pressure, the Korsakoff sounds are continuously heard, right? So the pulse pressure is increased. What happens to the apical impulse? The apical impulse will be because of left ventricular volume overload, right? So the apical impulse will be shifted down and out, or it will be displaced laterally. Okay. Will you find a thrill? Yes, you can find a thrill. You can find a diastolic thrill. You can find a diastolic thrill, and this thrill is heard in the left third intercostal space or the neo-aortic area. Left third intercostal space or the neo-aortic area is where you find this diastolic thrill. Now, on auscultation, what happens to the S1? The S1 remains normal. What happens to the S2? The S2 is narrowly split. The S2 is narrowly split and the A2 is usually soft. Okay, except in syphilitic AR where you have a tambour-like quality in syphilitic aortic regurgitation. Okay, fine. Will you find an S3? Yes, S3 can be there, S4 is absent. Especially when the patient is in LV failure, you can have an S3 and S4 is absent. Fine. Now, what about the murmur of aortic regurgitation? The murmur is an early diastolic murmur which is heard in the left third intercostal space, which is also called as the neo-aortic area, with the patient in the sitting and leaning forward position with the breath held in expiration with the diaphragm of the stethoscope. Okay, so this is your EDM murmur of aortic regurgitation. Now, what is the Cole-Cecil murmur? What is the Cole-Cecil murmur? If the AR murmur radiates to the axilla, the AR murmur radiates to the axilla, then this is what we call as the Cole-Cecil murmur. What is the Austin-Flint murmur? The AR murmur can radiate to the mitral area and appears as an MDM murmur at the apex, right? So, if there is an MDM murmur at the apex associated with the aortic regurgitation, then this is what we call as the Austin-Flint murmur. But how will you differentiate this Austin-Flint murmur from the murmur of MS? Because MS is also an MDM murmur. The MS murmur will be associated with an opening snap. It will be associated with pre-systolic accentuation of the murmur. Right? It will be associated with the pre-systolic accentuation of the murmur. So, this is how you differentiate the Austin-Flint murmur from the MDM at the apex or the MS murmur. Okay. Also, you can have an ejection systolic murmur associated with AR, which is not because of a concomitant aortic stenosis. You can have an ejection systolic murmur associated with the AR. But how do you differentiate it from an AS murmur? Because you can have an associated aortic stenosis as well. This is because this will radiate to the carotid, but the murmur of AR, if the murmur is due to AR, it will not radiate to the carotid. It will not radiate to the carotid. Okay, fine. So, this is about the various clinical features and the various clinical findings in aortic regurgitation. Now, let us move on to the assessment of clinical severity. So, how do you know clinically when you examine the patient whether this aortic regurgitation is severe or not? So, we look at the narrow split of S2, presence of peripheral signs, length of the murmur. This is seen in MS as well, right? Length of the murmur. If the murmur is longer, it means that the aortic regurgitation is more severe. Presence of Austin-Flint murmur and presence of LV dysfunction. So, these are the 4-5 clinical characteristics which help you know whether the aortic regurgitation is serious or severe or not. Okay, fine. Now, let us move on to the investigations. What do you see in the ECG? You can see evidence of left ventricular hypertrophy. You can see evidence of left ventricular hypertrophy. And because this is a volume overload state, you can see some amount of tachycardia as well. Okay. On the X-ray, you find cardiomegaly. On the X-ray, you find that there is cardiomegaly. How do you know there is cardiomegaly? You basically look for this ratio, the cardiac ratio to the phrenic ratio. If it is more than 0.5, then it suggests cardiomegaly. Why is there cardiomegaly? Because of eccentric dilatation of the LV. Okay. Now, we see what we look for in the AR. Fine. So, on the echo, there are certain things that you have to see. How will you know that this is a severe AR? Now, few things that you have to remember is, first thing is your vena contracta. Vena contracta basically refers to the narrowest portion of the regurgitant jet is called as the vena contracta. If the vena contracta is more than 0.6, apart from that, if the regurgitant volume, the amount of blood that is coming back is more than 60 ml, it's more than 60 ml, and the regurgitant fraction is more than 50%, or the effective regurgitant orifice is more than 0.3. You remember the number 653. Not very important high level stuff, but it's a good to know topic, right? So regurgitant fraction basically means that if 100 ml of blood is flowing in the forward flow, 50 ml of blood is flowing back. What is the regurgitant fraction? It is 50%, right? So that is your regurgitant fraction. And effective regurgitant orifice is you take the diameter of the regurgitant flow. So if this is more than 0.3, if all of these features are there, this is what we call as the severe AR. Okay, this is what we call as the severe AR. If the patient is symptomatic stage B, he is having symptomatic severe AR, or he is asymptomatic in stage C, but the EF is less than 55%, or he is undergoing other cardiac surgeries, or you are seeing that there are progressive changes, then you do a aortic valve replacement. Moderate AR only if the patient is undergoing some other cardiac surgery, then you go ahead and do a aortic valve. Okay. So this is about the indications and the management of aortic valve disease. So this brings us to the end of the session on aortic regurgitation. We have learned about the etiology of AR, how do you examine a patient with aortic regurgitation, what are the clinical features, and how do you manage aortic regurgitation. So I hope you have enjoyed this session. See you next time. Thank you.